Gabrielle, thanks so much for coming along and giving us this talk today. And for that matter, thank you for your interest in activities within Australia as far as interRAI is concerned. It's greatly appreciated. So we did ask you some time ago about how interRAI works for small aged care providers, and you've kindly offered to tell us about that today. So may I hand over to you, and we're very interested to hear what you have to say. Thank you.
Thank you, Len. So today I'm just going to share with you a case study of a small aged care provider utilising interRAI within New Zealand. Just to give you some context, or to remind you of the context in New Zealand, we have interRAI carried on a single software platform nationally over here. The use of the long-term care facility assessment is mandatory across all our aged care providers. The use of it is to create individualised care plans based on the assessment outputs. That process is auditable in New Zealand, and the information needs to be transferable with the person if they move around the country. The users of the assessment, the facilities, also get 3 monthly reporting back in terms of their data. So that's just to give you a little bit of a background. So this particular facility is just a small rest home. It's 23 beds. It's run by 2 sisters. They only provide rest home level care. They don't have a hospital or a dementia wing. It's a rural setting right next door to the GP. They're quite well supported by their community, but survival was quite tough financially for a small facility like this. So they came to me when I was actually working as a interRAI educator and said, what could we do with the software here? We're having to complete our assessment 6 monthly or for changes of level of care. We can't afford a client management system. The software seems to be quite comprehensive for our needs. Could you help us? They wanted to have accessibility for all their care staff, everybody working off one platform. They wanted to be able to have their medical nursing information in one place, still had to meet the audit requirements when the auditors came in, and they also had the additional challenge of how they manage respite clients whose files would sit outside their facility. So what they were looking for was a patient management system where those social needs of the person, their medical care and nursing care could all be captured in one place. So we looked at the software as it stood, and when you break it down, there was already a lot of information built into the software that carries the interRAI assessment. Obviously, we had a demographics page, diagnoses, safety alerts. There'd been the addition of advanced care directives and end-of-life instructions, GP. There was a function that enabled the users to look at the date the next assessment was due and when the care plan was due for review, the actual assessments, or the outputs of those assessments. There was care planning software available, progress notes and reports at both resident and facility level. However, the rest home wasn't utilising all of these because they had been very focused on just completing the interRAI assessments. So if we did a little deep dive into the sort of reporting that was available, this is just an example of the falls tracking monthly summary. There was falls tracking, infection, active and recent wounds and vital signs already developed in the software ready for facilities to use. So this was just an example that gives you some of the reporting they had over a 12-month period that they could pull down. And on the front page, I've just taken some screenshots of the sort of detail of information that they were able to input into the software. The actual vital signs, the weight and height measurements would auto-populate into the actual interRAI assessment as well to save them recording things twice. And some of these reports, particularly this one with the active and recent wounds, had the ability to upload photos of the wounds and share those as well with others that had access to the software, such as district nursing services and things like that. So we wanted to talk about how we could make this more useful for them as a platform. The core activities still remained around assessment and care planning, And what we needed to do, what we needed to include for those to be successfully done and auditable. A lot of the work that occurs around the inter-RAI assessment is actually the information gathering. So the long-term care facility assessment will talk about a 3-day look-back period or a 7-day look-back period in some places, sometimes 90 or 180 days for falls. So we wanted that information to be very easily available to the RN responsible for completing the assessment. There was an assessment summary, which I will show you, that's been added to all of the assessment instruments in New Zealand that helps the assessor consider how they're going to respond to CAPS before they complete a care plan. Obviously, the CAPS and outcome scales, and then the ability for some of that information to be auto-populated into the care plan, and who was actually going to complete all of those parts of the care plan. So part of this was developing some additional records for this facility. They wanted a short-term care plan because in New Zealand, there should be one completed within the first 24 hours of admission based on the previous home care assessment. They needed somewhere for their caregivers to record daily activities and responses of the person they've been looking after. And they already had some record sheets that they wanted replicated into the software. And the activities coordinator needed to report monthly on how people were socialising within the facility, and they also used a weekly report. So these were some of the things that we needed to build into the software, and our software provider had a forms creator capacity, so we were able to tailor make these for this particular facility. I had to throw the cookies in here because this was some of the baking that the actual facility residents did one day. They share this with us. In order to do this, we also had to work out a plan for educating all the team that would be joining up to use the software. So at the beginning of the process, we had only the registered nurses with access to the software. They didn't have a receptionist, and one of the RNs was the manager. We needed to get all the caregiving staff and diversional therapy staff access to the software. And we also knew that if there is a long lag or delay between learning to use a new piece of software and actually putting it into practice, often people run into problems. So we worked out a schedule of work and then began with each phase of implementation. We organised training sessions for the caregivers, and as they completed their training, they started to utilise the daily record in the software on that shift. So we had a transition period of about 2 weeks to get all of the staff transitioned and trained into the utilisation of it. But as each group trained, there were other staff around them who were already utilising the software and able to support them with doing that. By the time we completed that process, we made the next obvious move to a train the trainer model so that the RN was actually able to do that training herself and wasn't reliant on our educator team to continue to do that work. That meant if they brought new staff on over time, they were able to train them immediately as part of their induction to working at the rest home. So here I've just got the very basic screenshots of some of the forms that we created. I've blanked out details, obviously, but it gives you an idea of the sorts of things that they wanted put into their software for reporting. And this is where they do a review of the goals for the person's activities in the rest home. You'll remember that I mentioned the assessment summary, which is software that, it's a tool that we had added to our actual assessments in the software right throughout New Zealand. And the assessment summary is the last screen when you complete an inter-RAI assessment, where you consider the triggered CAPS. You'll notice in the second column here that it has an addressed and care plan tick box where the assessor can determine whether or not it will be added into the care plan. If our rule of thumb has been that if something's triggered and you're unable for some reason to address that, then you would give a rationale here as to why. But there may be untriggered caps. For instance, here we've got the undernutrition cap that hasn't triggered. The person does have a reasonably high BMI and is diabetic. And so the nurse is still including that into the focus of care in the care plan. So it's a good place for auditors to be able to see how the assessment outputs are actually going to be linked to the plan of care. The other thing you'll notice is that the scales from the assessment have been quoted in here too. So we do educate the assessors to be considering the scales and to think about how those scales interact with the CAP to inform the person's capacity to either be supported to prevent decline or have some improvement in function. The care plan itself had CAPs come forward into there that could be utilised. So you'll see down here that they've written a set of goals, and over this side there are the associated CAPs. So it's very clear again that there's a linkage between the plan of care and the assessment. And then when then you can do a deeper dive into the actual details of how a particular issue is going to be addressed in the care plan. So in summary, we already had a comprehensive assessment tool mandated here with interRAI. This just gave this particular facility the opportunity to add comprehensive information around it. The fact that all of the daily reports from the caregivers was inside the software meant it was very easy for the RN to look back at those notes and to consider the function over the 3-day back period. The medical notes were being added into the progress notes so that there was visibility of those available to the RN completing as well. It's desktop reviewable, so when the needs assessment service in Nelson is able to consider a reassessment for change of level of care, not only could they see the assessment sitting there, but they could see the information around it, which meant that there was complete transparency around how that assessment information was gathered. Certainly no gaming if you've got all of your patient's notes in there as well. It moves with the resident. This particular facility was evacuated at one stage when we had some very bad fires in the region, and the residents were moved to other facilities who all commented on how amazing it was to get a file that was so complete around the person. It's kept the staff involved, and so the staff involvement is at every level, and they have a better understanding of what the RN's doing because they can see the assessment as well. They want to have a look at it. And overall, the facilities reported that they feel they have more time with their residents as a result of keeping everything in one place. You will probably ask about medications, and that is the only thing that's sat outside of the software. They use Medimap for the medications, and so they are using 2 platforms in order to manage that. That was one step we couldn't support them with. And finally, this lovely photo is one of their residents who's out at a place called Rabbit Island in Nelson when they went out enjoying a picnic. So I thought he was a good one to finish with. And thank you.
Well, thank you, Gabrielle. That was fantastic to hear that. Have you got time to answer a few questions? I'm sure people have them. I'm going to start, if I may. So in New Zealand, you use a centralised software solution for regulatory reporting. When you talk about software, how does it relate to that, or is it the same thing? What's the software arrangement in regard to the centralised system?
Certainly. So we have a software provider that the Ministry of Health in New Zealand selected at the time that they decided to implement interRAI. They chose it because the model itself was the best fit with our current health system. In order, New Zealand has a national health index number for everybody within the health system. the way that it was structured, it would work very well for our needs. So that platform was they signed up to utilize that platform, and it was a platform that interRAI International recognised and had work with in order to carry the interRAI assessment. So that meant that for the stakeholders involved when interRAI was made mandatory, the requirement on them was to have the hardware that would meet the needs of that software implementation, but they didn't have to pay for the software or the upgrades to that software because that was managed under the ministry's contract.
So when you talk about the software here, is that software that you sort of modified? Is that right?
Yes.
Okay, then I understand it. Okay, would other folks like to ask questions? If you could pop your hand up or just speak, I'm happy either way. Yes, Nancy.
Gabrielle, I mean, if it's a small home, do they just have, do they have a centralised sort of computer system that they enter all the notes on at the end of the day, or do they go around with iPads, or what's the situation for the recording?
That's a good question. They are using a centralised workstations. It is a very little facility, quite an old facility, as you can tell by the photos. It's not newly built. They haven't got moved to iPads, and it's so they have a centralised nursing station where they do their they record their notes, but they have enough set up to manage that workflow with their caregivers finishing shift. Yeah.
Thank you, Murray.
Hi, Gabrielle. Nice talk. Thanks for that. That nationally provided software system that you talked about, so that's allows people to upload their interRAI based assessment data as a kind of reporting requirement, but it looks like it provides them with an analysis of that assessment information in terms of the scales or the caps. Is that something they have to opt into, or have I got that wrong? Or, is it something that they see by default and choose to use or not to use? Because some of the larger providers would have like a care management system or a clinical management system that would have some of this decision support or care planning functionality built in. So what?
The way the software is set up, every at a patient level, each patient has each resident has a file. The file will provide a demographics page and the interRAI assessment instrument. All of the other things like care planning software and reports is all there, but a lot of the bigger facilities, as you say, haven't opted in to use that because they have that already in other systems. And that's fine. There's no mandatory requirement for them to do that. Where it works for the smaller facilities is if they can't afford the alternative, then they've actually already got it. So it's freely provided, which was the lovely thing. In terms of reporting, they can decide to use some of that internal reporting for their own auditing requirements. We have health and disability sector standards in New Zealand that they have to report to. In terms of analytics, when it comes to caps and outcomes, so you can see them at a client level. The reporting, it is gathered by interRAI services. So we have a data warehouse that all of that goes into, and we have reports set up by our analysts that are fed back to the stakeholders quarterly. So they don't have to gather their reports. We give them back to them in terms of what their data looks like and their quality indicators. But also there's an analytics capacity built into the software. So as an individual manager, if you had a particular project on, you can do an analytics training course through our service and run your own queries over your own facility information too.
Great. And just jumping in ahead of Ronald, sorry, Ronald. Those reports that are sent back, or the analysis of the data that's sent back by the central boffins to the providers, is that at a resident level, or is that an aggregate? Is it like at a kind of
They only see their own data for their own facility, so it's locked down in that respect, so they can have NHA level data at that point. Yes, and then because it's contractual with the local district in terms of that completing of assessments, then the aggregate version of it is going to whoever the contract holder is. We've recently changed because we've become one big national team, so it's under commissioning that they get a copy of that too, so that they can walk alongside any facilities that are having problems with service provision, etc., and target those areas.
Fantastic, thanks.
Okay, Ronald, and then Katie, and we might have to stop at that point because I think Gabrielle's got other business she has to attend to. But Ronald?
Yeah, thank you, Gabrielle, for that presentation. That was really fantastic. I actually had two questions. The first one is relating to the benefits that you listed, what kind of study you conducted to come up with those benefits, as well as whether there is any publication that we can refer to. The second question was with regards to quality indicators, and you've already touched that in your response to Murray, but I was wondering if you can shed more light as to how the facility is using those quality indicators, whether it's just for reporting or they're using it for their daily care of their residents.
Certainly. So in terms of the study done to implement this, there wasn't one. The request came in at that time. We hadn't actually done this piece of work before, so it was a very much a pilot. As a result, there was a lot of learning as we went along. So I worked very closely with those sisters to implement that, and I did prepare and complete an implementation papers. We did make some small changes to some of the forms that we developed as a result, and that was largely on their feedback as to what was working for them as a facility. So it was a very hands-on pilot. This work was completed in 2017, and they're still using it. So for us, some of this has been the proof in the pudding. The difficulties with it have been that as a service, our role through the Ministry of Health had been for implementing interRAI services, and it was really around the implementation of the assessment instrument, educating assessors, and helping people understand their data. So really going into that additional utilization of the software was a sideline. It wasn't really our core business. We did, off the back of this, get quite a lot of interest from small providers all around the country saying, can we do the same thing? And really, we weren't resourced to be able to do that level of support nationwide. So we haven't continued with it, not because it isn't successful, but really because it's outside our mandate. Yeah.
Thank you, Gabrielle.
For those of you listening to this conversation who may have further interests in interRAI systems, please visit our website, interRAI-au.org.